Said that informed consent serves what? Promote patient well-being and serves to respect patient self-determination. Now, we talked about promotion of patient well-being and patient self-determination, but we need to know how valuable the patient self-determination is in the patient-physician relationship. Then what weight should be given to patient self-determination healthcare? Now, patient decision, so when the patient decides what line of treatment he accepts, he is guided or she is guided by his or her well-being. This is what is good for him from his own point of view. Even the harmful decision does not abolish self-determination but reduce it. Now, the physician is playing as a guide for him against his harmful decision, but does not deny that he has a self-determination and we need to respect it under our guidance. More valuable to renal failure patient to refuse treatment since the treatment will not promote the well-being, and this is why the patient, when he said the physician ordered hemodialysis, he found that, or the patient found that he is not, the well-being of that patient is not promoted. This is why he is refusing this line of treatment. Therefore, self-determination is valued for what? The good consequences that result from respecting it. To respect self-determination means that he has a good feeling. He has a good feeling that, okay, his opinion is being respected. And this is what is called the good consequences. Instrumental in promoting well-being from the patient perspective, which is both objective and subjective, and not from the provider perspective. And for its own sake, as part of the ideal of the person. People value being self-determined and recognized by others as such, so they satisfy their ego. Means that he is free to decide for himself, and in each issue in life, to respect his self-determination satisfy the ego of the person. There is dignity in self-determination that is lost when self-determination is taken from him. If the physician feels that this patient, I'm not going to respect self-determination, means that he is taking his dignity. Everybody feels well if his opinion is respected. Even the wrong decision, sometimes we can correct it, but this does not deny the fact that self-determination is good for the well-being of the patient. When self-determination is being waived, the moral principle of the informed consent is that patient is entitled and not required to take active part in the decision. So the informed consent affirms that the patient has the right, has the right of what? To make decision for himself because he feels that it promotes the well-being of the patient, but not required to take active part. So this is my right, and sometimes I opt not to use it. But this does not negate the fact that it is his right and he is entitled for it, but does not mean that he is required to use it. Patients tend to waive self-determination because when they are gravely ill, he's gravely ill, he doesn't like to take decision. He doesn't like, it is his right, but he doesn't like to take decision when he is gravely ill. So he can, the guardian or the surrogate, the one who is talking about on his behalf, or even the physician can take the decision on his behalf. Thinking of illness make them more depressed. Again, if the patient when he thinks about his illness, make him more depressed, then he can waive the right to decide for himself again to the patient or to the surrogate. Lack of technical knowledge and ability to decide. And this is if the patient feels, or when we evaluate the patient, if he feels that he is unable to understand what the physician is talking about, and he is unable, sometimes there are certain people who are unable to decide for themselves, and they need somebody to decide on their behalf. But again, this does not negate the fact that it is his right or her right to decide for him or herself, but he is lacking the knowledge, the technical knowledge, and the ability to decide, and in this case, he can waive self-determination. And in the fourth place, that if he knows the provider, and this is the benefit of the continuity of care, which means that to see your own physician, this is to create a good relationship between the physician and the patient. And then when he know the provider or the physician and they trust him, then whatever decision taken by the patient. This decision is compatible with self-determination. He's satisfied in all these situations. He's satisfied with whatever decision taken, and the patient should understand that the decision is his to make and to transfer it. Now, this is another own decision, and you can transfer it to anybody. Take it. What is immoral? What is immoral is when patients waive the decision. Why? Because they believe it is not their business to decide. This is what is unethical and immoral. That if we come to to make the patient feels that it is not his business to decide for himself. It is his business to decide for himself, and to make him think that like that, which this is an immoral practice, and this is not an exercise of self-determination. Exercise of self-determination. So said that the patient is free to form, revise, and execute his decision. Now, exercise or execution of self-determination requires two conditions to be met. First, self-governing, which means that make decisions for him or herself after what? After weighing alternatives against their own values, weighing alternative against their own values. What this means that if he has to select between two lines of treatment, he compare each of these lines of treatment against what? Against his own values. Is it acceptable? Does his values approve the selection of this line of treatment or not, does not approve it? If it approve it from his own perspective and he compare it against his own values, so he select the line of treatment that is in congruence with his own values. This is what's called self-governing. So he's governed by his values to take the line of decision that meet his own values. And second, a well-formulated law that limit the misuse and abuse of the informed consent. Now we need to exercise self-determination. We need a well-formulated law that limit what? The misuse and abuse of the informed consent. Abuse or misuse by who? It is clear. It is by the physician. So we need a law that prevents the physician from misuse or abuse. What is law? This is legal. Now it is not ethical. Now misuse or abuse of the informed consent means you are legally bounded. Okay, the third characteristics of the informed consent is that it fosters public trust in medical enterprise, especially in areas of research, because we have to secure informed consent for each and every piece of research we do on patients. After explaining to him or her what is the purpose of the study, and we assure him that the data will be confidential and that he can withdraw, he can refuse to participate in the research, and once when he is convinced, then he can sign. This is then the public will trust the medical profession that they do their research after securing the consent of participation from the participants. Now, these are the positive aspects of informed consent. Now, some ethicists say that, okay, now if I'm going to detail all the information to the patient and the risk and benefits of each and every procedure available to him to select from, then this might have a negative effect on that the patient may lose the trust and faith in the healing power of the health provider. Then where's the rule if he is leaving the decision for the patient? Some people say, where is the healing power of the provider, which that every patient come to the physician and he is convinced that the physician has the power to examine and prescribe the correct decision, which is a weak argument from this ethicist. Now, the conditions of valid informed consent. Is there an informed consent that is not valid? Yes, there is an informed consent that's not valid. Then we need to know what are the conditions to make the informed consent valid. For a consent to be morally valid, three conditions need to be met. First, that the person giving the consent be competent. Which competent is necessary to ensure that the patient has sufficient decision-making capacity to participate in discussion and decide responsibly on the course of treatment. And this is, we discussed it, that this is what's meant by competence. Competence means that the patient is able to understand, able to comprehend, able to discuss, and then able to decide on the line of treatment selected. The second, the patient has to be informed to ensure that the patient has received all the relevant information. So a valid informed consent requires that the patient to be competent and that the patient receive all the information needed by the patient to make his or her decision. And the third part, which is that the patient consent be voluntary. Be voluntary means he voluntarily sign the consent. Levels of competence. Now, when we talk about competence, means that there are people with certain level of competence and others with certain higher level or lower level of competence. In terms of competence, there are three types of patients. First, clearly unable to consent. So the patient is unable to understand technical of medicine. He is unable to decide, unable to discuss, which is clearly unable to discuss. For example, like the child, mentally retarded, the comatose patient, or are clearly unable to consent. And those who are able to consent, who are clearly, when you talk to them, they understand, they discuss, and their discussion makes logics, makes sense. And the third are those who need evaluation. If they are not clearly competent or they are not clearly incompetent, then there is a mid-level population where you think that you need to evaluate the level of competence of those patients. And when you know that during the course of the discussion, during the course of informing, you might feel that the patient is not well understanding or is not well comprehending, or sometimes he decides on something that you feel that he is not understanding the whole situation. Those are the people who need evaluation. Competence is important because why? Because it differentiates between those whose informed consent is honored and those whose informed consent is set aside. Clearly unable means the informed consent is set aside. He cannot sign. And if he sign and a mistake happen, he is not responsible for his signature. So again, you are legally binded if you got the signature of those who are clearly unable to decide for themselves. The evaluation is actually now, if you are going to evaluate the level of competence of the patient, then how you are going to evaluate? Is there a method? Yes. So it is an evaluation between patient well-being versus patient self-determination. Sound decision means that the patient has a sound decision is the one that ensures balance between well-being and self-determination. If you find that patient decision is balancing between his well-being and his self-determination, which means that this is a sound decision. We'll explain this more. When patient decision is right, the two are promoted. When he decides rightly, then his self-determination is secured and his well-being is also ensured. So this means that the two components of the service of the informed consent, which is well-being and self-determination, are both in agreement with each other when the when the decision is right. But when the decision is wrong, the two are in conflict. The two are in conflict. He might be promoting well-being, but not promoting self-determination, or vice versa. He might be promoting self-determination, but not promoting the patient well-being. That is when the decision is wrong. Let patient decide, and this is when you are in dilemma of evaluating the patient. So we let the patient decide for him or herself, but if he has a harmful decision, we need to protect him. So we are not passive in this, leaving the decision for the patient for whatever he decided for. We only interfere when the decision you feel it is wrong, then we need to protect the patient against the bad consequences of his or her wrong decision. There are several points that need to be considered when evaluating the patient level of competence in medical decision. Competence is always relative to a particular task. Competence is always relative to a particular task, which means that if the task at hand or the procedure at hand or the line of treatment at hand is very difficult, then we need a highly competent person. When the decision or the task at hand is simple, like do you prefer ampicillin capsules or penicillin injections? It's a simple task. So, and both are effective. His decision between these two, either two, does not require high level of competence. So the competence is always relative, depending on what is the discussion, what is the disease at hand? What is the health problem at hand? If it is simple, like a preference between ampicillin capsule or penicillin injection, we need a lower level of competence. But when it comes to an open heart surgery, when a patient needs an open heart surgery and he selected a less effective line of treatment, then we need to interfere to protect the patient by evaluating him and requiring him to have a high level of competence. Patient's decision-making competence changes over time. This is another thing, that if he is competent in one occasion doesn't mean or doesn't grant him that he is competent on all occasions. Over time, the level of competence might change. Clearly, when the child reaches beyond the 18 years of old, becomes competent, not before that, or sometimes the patient is competent, but when he goes into any disease that affects the level of competence of the patient, over then he becomes incompetent. So the decision-making competence changes over time, and there are varying degrees of capacity contributing to having or not having competence. Yet, the final decision will be that the patient is competent or not competent. Now, the degrees of competence, varying degrees of competence. Varying degree of competence means that sometimes uh, uh, for the same person, in one occasion he might decide rightly, in another occasion he might decide wrongly, and again the level of competence between people it varies. Now we cannot say that he has 80% competence or 90% competent or 60% competent. We can't calculate competence by the percentage. Now, our decision has to be yes or no, 0 or 1, competent or not competent. It's not 80% competence. I need the physician to tell me whether he is competent or not. It's not enough to say that he has 80% competence. Now, the crucial question then is how defective the patient decision making to consider him or incompetent. At what level of competence we can, the cut point between competence and not competence. You know, all the exams, maybe 50% is the cutoff point between success and failure. Again, we need here a cutoff point beyond which we consider the patient competent, and below that we consider him or her incompetent. Now, what are the elements or requirements of decision-making competence? There are three levels of competence. These are for for evaluating the competence on. First level, which is the simplest form, the ability to communicate and understand relevant information. That's more than enough for a decision to be taken at certain medical conditions when the patient is able to communicate and understand what the physician is talking about. The second level, which is more complicated, is that the ability of the person or the patient to make reason about different alternative treatments, benefits, and risk. Now, I select this line of treatment because this is a reason, because of so and so and so and so. So the first one is just the ability to communicate and understand. The second, to make a reasoning for his decision. Why you selected this line of treatment? Because so and so and so. What are the benefits and risks? And by talking about the causes or the reasons behind his selection, then you can evaluate better the level of the competence of the patient. And this is second level of competence. The third level of competence, which is the highest level of competence, that the patient possesses values and goals against which to assess a treatment. He's talking more than communication, he's talking more than understanding, the patient is talking more than reasoning. He's talking about the relationship between his decision and his values and goals. I cannot do this because it contradicts with my values. It contradicts with my goals. So he has broad thinking of reasoning, not only because this is more beneficial or this is more risky or this is, but again, he is comparing now his decision that meet his own goals and values. Uh, like as we said before, cancer, sarcoma of the lower limb. For certain people, they look for radiation therapy and chemotherapy. For others, they look for surgery. Now, the two lines of treatment selected, each one select the line of treatment that meet his goals and values. For Emmanuel Worker, he needs his leg. So the decision is based on that the need of the leg force him to work on radiation and chemotherapy, but not on surgery. So this is his values, this is his goals in life that determine which line of treatment to use. Now, the absence of solid measure of competence reflects the complexity of the issue to the extent that decision of competence made by physician or the course appear as if it is arbitrary, which is not true. Now, we talk about ability to communicate, understand. We talk about the reasoning. We talk about values and goals. By looking into these things, we think that there is no objective, solid, accurate measure to measure competence against. And some think that the decision of competence or not competent is just an arbitrary, but which is not the case. Now, then what are the levels or standards of competence? The minimal level of competence required by the patient is the ability to express a preference regardless of how this preference is expressed. This is the minimal level of competence, and we require this level of competence, as I said, in simple decisions. In simple decisions between antibiotics, cheap or expensive antibiotic. This is the minimal ability to express his preference, and regardless of why he said or he selected, we don't ask him, why did you select between ampicillin capsules or penicillin injection? The second, this level of competence, this level of competence, if we said that the patient is competent and he expressed his preference, then here we promoted his self-determination because we respected his decision, but does not, if we look into this level of competence for the patient, this by evaluating the patient's level of competence on this minimal ability to express a preference means that we don't provide any protection patient well-being against the consequences of defective decision. Why? Because we looked into his preference and we did not ask why you select this preference. And in this case, if there is bad consequences for his selection, which is related to the well-being of the patient, then we are not providing, or this level of competence is not providing any protection of the patient well-being against the wrong consequence that might appear during the course of treatment because we respected his decision and we did not ask why you selected this preference. And it fails to balance self determination with well being in favor of self determination in this level of competence. If we said that the patient is competent, this means that the self determination is respected, but the well being is not protected, which means that there is no balance between the two. As we said before, a sound decision that balance between self-determination and patient's well-being. If we evaluate the patient level of competence by just his ability to express a preference regardless of how this preference is expressed, then we are promoting self-determination, but definitely we don't protect against the patient well-being, and in this case there is failure in balance between patient self-determination and patient well-being. The second level اللي هي standards evaluating the content of patient decision. Now we need to look into what the patient is talking about, what the patient is talking about, why the content of patient decision, not just the preference of the decision, but rather it is I select this treatment, I select this line of treatment because of so and so and so. Then we look into these because of so and so and so. Does it make sense or just naive? Competence is determined by evaluating the content of patient decision, whether in agreement or not with physicians or family is what triggers the evaluation of patient's level of competence. Now, the content of his decision, we evaluate the content. And if the content of his decision is in line with the physician way of thinking or with the family way of thinking, then it's okay. He's competent. Now, when we start to evaluate more, when his reasoning or the content of his decision or the content of his speak is not aligned or in disagreement with what the physician or the family think, then it triggers us to evaluate more. What do you mean? Are you talking about something that is in disagreement with our way of thinking? Now, the physician knows which line of treatment, he knows the benefits of each line, he knows the risk of each line of treatment, but he's leaving the patient after giving all the information, leaving the patient to decide for him or herself. But again, we said that we need to protect him against the wrong decision. Now, if he's talking the content of his speech in this line of treatment is not in agreement with what the physician think the best for him, then this triggers us to evaluate the patient's level of competence. To judge the competence by content of decision requires an objective standards of correct decision independent of whether that standards conform to patient's values and goals. Then we need, as physicians, to evaluate the patient against what? Against some solid standards, some solid objective standards, regardless of the patient's goals and values. What are these objective standards? The objective status is determined by what correct decisions might be those which are rational. When the patient speak or talk about the content, is his talk is rational? If it is yes, then this is the standard or this is the objective standard we compare the content of patient physician against the rationality of his talk. He talks irrational. If it's talk irrational, this means that maybe he's not competent. Up to this moment, we need to question the competence of the patient if he's talking irrational, what we think is irrational. The second, what most people would decide in similar situation. Now, the physician, from his experience or her experience, knows that in this situation, if I took, for example, 100 patients with the similar conditions, what would they decide for? Which line of treatment they have decided? Is he among those 100 or he's talking totally different from those? So, which, what most people would decide if they are in his or her position? The third one, which is what the provider would decide. The third one, it is the physician decision. If I am given the freedom to decide for this patient, would I decide what the patient decide for or differently? So these are the standards or what we call the objective standards against which we evaluate the content of patient against. This approach of comparability denies patients' capability of self-determination since objective standards are not always defensible. Again, the debate is going on. This issue is not yet settled whether to evaluate patient competent or not according to these three objective standards. Still, we deny the ability of the patient self-determination by comparing the content of his speech but according to these criteria means that objective standards are not always defensible. What if most people decide if their situation decide differently or decide like the patient? Again, this standard is not uh, gold standard, for example. Again, what is rational and irrational? The, in given his situation, we talk about patients who are talking or accepting a line of treatment that is according to their own values and goals. Now, rational or irrational from the physician point of view differs because he is not in the mind of the patient of what he is thinking of. Third one, this decision is against the physician decision. Again, this is cannot be defended because if this is the case, then whatever the physician decide is the right one, which is not truly the case because it is the right one medically, but it is not does not sometimes promote the well-being of the patient. It failed to respect patient's capacity to define his own values. What most people think, does the patient talk rational? Is his decision in disagreement with the physician decision, which is the gold standard? No, it is not the gold standard because if we take these standards and compare the content of the patient's talk according to these standards, this means that we failed to respect patient's capacity to define his own values, and it runs the risk of substantial abuse of patient's right to decide for himself. Why? Simply because it does not meet these three standards of rationality and the most people and the failure decision. Each and every patient is unique, has his own values. Then, in this case, if we compare this competence level by these objectives, means that we are running the risk of substantial abuse of patients' right to decide for themselves. Third level, which is our standards evaluating the nature of patient understanding and reasoning. The nature, which is deep. It focuses on the process of decision making, not only on the content of what he's talking about. He's talking about rational or irrational. Now we look into the process of decision making. Start, I'm using this treatment simply because of this and this and this. And by using this, then I'm going to save my children or I'm going to save other goals. It goes with my values. It goes, so it is a process. Process means continuous flow of way of thinking of the patient on deciding for himself. explore the patient's level of understanding and the reasoning process. So, not only explaining the level of understanding of the patient, but also we look into how he thinks, which is the process of reasoning. Any sign of misunderstanding. Now, sometimes the misunderstanding comes from the physician was unable to pass or to communicate well with the patient to give him what is needed. Now, any sign of misunderstanding, which is created from this miscommunication between the physician and the patient, warrant further discussion. No, I don't mean that. I meant, this is the physician saying, I meant that this is the risk of this case is so and so, the risk of this line of treatment so and so. This is what I mean, which create more and more discussion by just observing how the patient is reasoning his acceptance of line of treatment. Now, if the mistakes persist from the patient from the patient, then this a good justification to declare that the patient is incompetent because his way or reasoning process is not congruent with what he understands. Either he doesn't understand what the physician is talking about, or sometimes even the process is not going in line with the well-being of the patient. Third, it fosters patient participation decision making. By looking into the process of reasoning, then we look into more active role of patient in the decision making process that conforms with the patient goals and values. These are the characteristics of when we evaluate the patient on what? On the nature of patient's understanding and reasoning. Focus on the process of decision, the process of the decision making, not only the preference or the content. It also explore the level of understanding and reasoning process, so any misunderstanding can create more discussion. And if the misunderstanding continue, this means it's competence. Third characteristic of this level is it fosters patient participation in decision making. It's clear that the patient is active in the decision making process during the discussion. And then it seeks a balance between patient's self-determination and the protection of patient well-being. Third, next, the patient found understanding and able to reason his decision, then the decision should be honored. He passed the test. Patients found clearly unable to understand or reason, then declared incompetent would justify transferring the decision into a what is called a surrogate. Surrogate means the one who is able to decide on behalf of the patient. The consequences of acting on patient decision, range from being better to being worse, which comparison now consequences of acting on patient decision range from being better or being worse. Now, this is the patient decision. Now, the consequences of acting on this decision might be better or worse compared to what? Against the alternatives. Is it better than the alternative or worse than the alternative? Consequences, long-term consequences of what is selected by the patient as decision. Is it the comparison is against the alternative and the net effect of risk-benefit balance of each alternative. In favor of patient choice, then it is reasonable to require a minimal level of decision-making capacity. In favor of patient's choice, then it is reasonable to require minimal level of decision-making capacity when the comparison against alternative and the net benefit, the consequences better, then we are in favor of the patient decision. But if the expected effects are worse than available alternatives, then we require a high level of competence. Tell us why you selected this in more details. If we think that he is selecting a lower level of alternative, then we need to explore more why he selected this low level alternative when there is a more superior way of treatment. If the expected effects for life and health of patient is comparable to that of alternative, a moderate level of competence is required. If the expected effect, now we compare between alternatives, if they are equal, then we need a moderate level of competence. So the level of competence required by the patient on his decision depending on by comparing his decision against the alternatives and against the net effect of the risk and benefits. If it is the selected alternative is lower than or equal, we require minimal level. If worse, we require a high level of competence. If the expected of effects for life and health of patients is comparable, then a moderate level of competence is required. One final precaution should be emphasized that the level of competence for consenting to and refusing a treatment need not be the same, as the consequences of each of them on patients' well-being may be dramatically different. So, which means that consent or agree to do this operation against refusing this operation. The level of competence need not be the same. Which which one of those require a higher level of competence? Patient refusing a clearly beneficial treatment. This is one patient, and the other patient is accepting a line of treatment. Seems clear that we need from those who refuse clearly beneficial treatment to be of high competence, high level of competence. The high level of competence is required from those who refuse clearly beneficial treatment. At the beginning, we said that legally you cannot provide medical care to a competent patient without his consent. Now, if he refuses your treatment, this refusal triggers that we need to evaluate this patient for his level or her level of competence, and we require him to have a high level of competence compared to those who signed accepting treatment. This is why consenting to and refusing treatment, the informed consent is not, or the level of competence is not the same. We insist that the patient fully understand that he is refusing a life-saving therapy with limited risk, while we should apply less strict standards to those who accepted this therapy. While determining the level of competence is left to the discretion of those who make this judgment, legal and professional practice must be designed to limit the unjustified use of this discretion. Now, what does this mean? This means that level of competence judged by the physician. It is left to the discretion of those who make this judgment. Now, legal and professional practice must be designed to limit the unjustified use of this discretion. إذا احنا قررنا this patient is competent or not, معناته we need a law that protect the patient from this discretion to be misused or abused again. Second, قلنا a valid informed consent requires competence, it required to be voluntary, he signed against or refused uh, voluntarily, means not coercion, consent under threat, or forced treatment involved no consent. Sometimes you go for treatment without consent, or sometimes you threaten the patient. If you don't do that, your life at jeopardy. This is coercion if it is not the case. So consent signature for the consent has to be voluntary, not coercion, not forced treatment. Coercion by the disease itself. This disease is very serious, and if you don't do so, there was so and so and so and so. So his coercion, the patient or threatening the patient or making the things worse for the patient in order to accept or to get afraid and accept what is required by the physician. Or manipulation. Sometimes, especially in private practice, you go and they ask between two alternatives like surgery of back pain or medical treatment for back pain, and you know what the benefits the physician is going to get from surgery as opposed to medical treatment. He starts to manipulate with the patient, certain physicians, or might be manipulating the patient that uh, manipulating him, trying to convince him smoothly that this is the case with these are the benefits you get from surgery, these are the benefits against the risk getting from medical care. Just manipulation. Manipulation means that trying to convince the patient to a line of treatment that is favorable for the physician from his patient, his interest. Manipulation. Now, the third component for a valid informed consent, which is information. We need to provide information to the patient. We need the consent to be voluntary. We need the consent to be signed by a competent patient. Now, when it comes to information, which is to achieve a sufficient understanding of their condition so that they make sound assessment of the decision. This is the ultimate goal of providing information, is to let him understand his condition and then decide for what action to be taken. Provider looks to the information as a protective measure against legal liability, uh, which is which is true. Now, by providing information about the physician means that the patient has been told each and everything about his condition, وبالتالي to protect the physician from being liable, disclosing the risk of procedure to protect themselves. Although consent would not protect against malpractice. Now, let's talk about malpractice. Malpractice means wrong consequences that occurred as a result of negligence. Negligence. Consent would not protect you as a physician from from being negligent. With consequences that should not happen, but because you are neglecting certain things, then these bad consequences happen. Then we need to know that the consent would not protect against malpractice. Yet, this is not the ethical basis for informed consent that requires the provider to give patient all relevant information in what? Not in medical jargon, but in format that the patient can understand. Patient needs not to be knowledgeable as the provider to make a sound decision. But once the information passed to him in a format that he can or understand, then he does not need to be knowledgeable as the provider in order to make a sound decision. Information might terrify the patient and prevent him from taking a decision. This requires to define the kind of and amount of information that ought to be recommendation. Now, that's true. Sometimes providing information to the patient might be terrifying for the patient. This is what happened. These are the risks, which is terrifying for the patient and might prevent the patient from taking any action. But this requires to define the kind and amount of information that ought to be communicated. Now, kinds of information, if we are going to tell the patient about his condition, what you are going to tell him? Going to tell him about his current medical condition, what you found by the exam, from the history, from the investigation, X-ray lab, whatever. Now you came up with certain hypothesis about what this disease could be. This is the clinical or the medical condition of the patient. After putting the diagnosis or the provisional diagnosis, then you select the line of treatment to be used for after the diagnosis. This is another piece of information that the patient is required to take. Third, recommendation to the best alternative and financial cost of each. You can recommend to the patient which is the best alternative from your point of view as physician. But again, it might not suit you if it goes against your values or your goals or your situation or your social status or your financial status. Again, because again, the financial cost of each of them need to be clear to the patient. Amount of information, how much you give about the current medical condition, how much you give about treatment. Now, amount of information controversial is standard for a provider, standard for the general person, invite the person to ask a question if he needs. The standard for the provider or the standard for the general person, then you leave the door open for the patient to ask whatever he needs to ask to clarify all these issues. Now, is there a conditions where you can't treat without consent? Yes, there are certain exceptions for treating without consent. First, physicians' fear of serious harm to patient if informed of his condition. Patient with a suicide tendency, he is psychologically ill and there is certain suicide tendency as investigated by the psychiatrist, then you can treat without consent. Definitely the incompetent patient, his consent is not going to be honored, or patient waiving consent to someone else. He's competent, but he tends to waive or he wants to waive his decision to somebody else, family, father, mother, husband, wife, and in emergencies. When a patient reaches the emergency room and there is a threat for life, then you don't need to wait for informed consent to be taken before securing the ABC for this patient. Giving due weight to the value of personal well-being while respecting the individual's self-determination morally requires gaining and honoring the informed consent and voluntary consent of competent patients for their medical treatment. Thank you.